Well, the main aim of recruitment maneuvers is, as Fernando told us, is to provide enough transpulmonary pressure for enough time so as to open up the lung and keep the lung open. And this has to serve to use or to employ our usual PEEP and tidal volume settings so as to avoid repetitive opening and closing phenomena. And why? Because there is a huge amount of data in the literature indicating that if we allow a lung to open and closing repetitively, this will induce a sort of ventilator-induced lung injury. But what happens in ARDS patients when we use these recruitment maneuvers? First, I'll go through these because there are different types of recruitment maneuvers, and we will see how the type of the maneuver may influence the hemodynamic consequences. This is, for example, work by Pesanti's group undertook in 15 ARDS patients. All these patients responded to a PEEP trial, and the group of patients were ventilated with low PEEPs below 10 centimeters of water, a high PEEP level, 16 centimeters of water, and the patients were submitted to a controlled, volume controlled mechanical ventilation with a volume recruitment maneuver, which was an increase to a high PEEP level, 2 breaths for or every 2 minutes. And what the authors observed was that when they were using the settings of controlled mechanical ventilation with high PEEP, the PO2 was significantly higher as comparison with the low PEEP as expected, but also was significantly higher than the strategy with this sort of recruitment maneuvers. So they concluded that recruitment maneuvers were less effective than a continuous high PEEP level. And what happened from a hemodynamic point of view during this study, you can see here a different number of variables, cardiac output, mean arterial pressure, mean pulmonary artery pressure, wedge pressure, etc. And you can see that overall there were no major changes in any of these hemodynamic parameters. Again, another study by Pelosi and co-workers and using sides as a recruitment maneuver, and these were sides in the form of 3 consecutive breaths each minute with a tidal volume high enough to reach a plateau pressure of 45 centimeters water. No, the minute ventilation was kept constant, and here you can see the open or the white bars, what happened in terms of changes in oxygenation, and these hatched bars represent the changes in arterial PCO2. And again, after the site, you can observe a significant increase in arterial oxygenation, which persisted 1 hour after the site. They observed that in these 10 patients, 5 of whom had a pulmonary ARDS and 5 of whom had an extrapulmonary ARDS, they observed that the sites were more effective in patients with the extrapulmonary forms of the ARDS. And again, from an hemodynamic point of view, when using this type of, say, gentle maneuver, the authors did not observe any change in cardiac index, and even they observed a slight decrease in the mean pulmonary artery pressure and in mean pulmonary vascular resistance. A slight but significant decrease. Again, this is more recent data by Patroniti and co-workers that was undertook in 13 ARDS patients, and again they used the strategy of the PSI, and the PSI was administered or titrated once per minute by adding a CPAP of 5 centimeters water at a level 20% higher than the plateau reached during pressure support ventilation. So, and this is seen here. So this is the CPAP side with the pressure 20% higher than the plateau pressure during pressure support. And again, what happened in terms of arterial oxygenation, virtually all patients showed more or less marked improvements in arterial oxygenation, and this was accompanied by a slight, though significant increase in the end expiratory lung volume. And again, from a hemodynamic point of view, no major changes in heart rate, systolic arterial pressure, or diastolic arterial pressure. But what happens when the recruitment maneuvers are more aggressive in the terms of increasing more the pressures within the respiratory system? Here, this is a study by Villagrá and co-workers, again in a large group of AJRCCM patients, which were ventilated with a strategy of moderate tidal volumes, and were ventilated with an external PIP, which was titrated according to the pressure volume curve of the respiratory system. And these individuals were submitted to a particular recruitment maneuver, which in this study was pressure control ventilation with a peak pressure of 50 centimeters water and a PIP level which went up to 3 centimeters above the upper inflection point of the pressure volume curves. So quite high PIP pressures and inspiratory pressures. And what they observed was, first of all, that the number of non-responder patients was pretty high. You can see here the individual responses in terms of the PO2-FiO2 ratio, and also when a group of patients with late ARDS were studied, the vast majority of them didn't respond to this recruitment maneuver neither. And here there is the data for the hemodynamic profile before and during the recruitment maneuver and after the recruitment maneuver. And you can see here how there is a major increase in the mean pulmonary artery pressure during the maneuver, which reversed after this maneuver was performed. Perhaps, most conceivably, this increase or this major increase in pulmonary artery pressure was due to the hypercapnia during the procedure when using the pressure-controlled ventilation. Again, this is data by Lapinski and co-workers, in which they used, again, relatively high pressure for a relative long period of time, and again, they observed significant decreases in arterial blood pressure, and in one patient, bradycardia happened. Perhaps, I don't know the reason of this, but perhaps I could speculate that hyperinflation could induce a sort of vagal reflex. And again, the effects of these untoward hemodynamic effects were rapidly reversed. More recent data, again by Grasso and co-workers, and using a recruitment maneuver with a pressure of 40 centimeters water CPAP for 40 seconds. And again, in this study, the authors defined the response as a 50% increase in the PO2-FiO2 ratio after the recruitment maneuver, and they observed that half of the patients responded, so improved arterial oxygenation, and half did not. And what they observed, again, was that patients with early ARDS, they tended to be responders, and in terms of respiratory system mechanics, what the authors observed was that the elastance of the lung and the elastance of the chest wall were higher in the patients who did not respond. In other words, the stiff is the chest wall, the less possibility or the less likelihood to respond to this particular type of recruitment maneuver. And again, in the patients who did not respond to the maneuver, the authors observed marked changes in terms of drop in cardiac output, drop in stroke volumes, in drop of mean arterial pressure, and a significant increase in the right atrial pressures, whereas in the patients who responded, no major hemodynamic disturbances were observed. So they concluded that this type of recruitment maneuver improved oxygenation in early ARDS and in early ARDS patients who do not have a stiff chest wall. And they even said that the presence of a stiff chest wall make the recruitment maneuver potentially harmful. Again, there is data using a particular type, again, of recruitment maneuvers, but in patients with cerebral injury. And again, you can see here how performing these recruitment maneuvers may, in some circumstances, impact the cerebral hemodynamics in terms of significant increases in intracranial pressure and significant decreases in the cerebral perfusion pressure. And again, effects that are rapidly reversible with time. 10 minutes after the maneuver, the effects disappeared. And this is some data that we have obtained in a multi-center study with Fernando, with our colleagues in Sabadell, using again a quite aggressive recruitment maneuver with plateau pressures up to 50 centimeters water and pips of up to 35 centimeters of water at the end of the maneuver. And as expected, major changes or major improvements in oxygenation happened. But you can see that arterial PCO2 increased enormously during the maneuver. I have to say you that the maneuver was performed with pressure control ventilation, and the tidal volumes during the stepwise increases in the values of PEEP and plateau pressures were accompanied by this decrease in minute ventilation. And this is what individually happened in patients that also had a Swan's-Ganz catheter. And you see the individual changes in cardiac output. So you see that at the very end of the maneuver, there is a significant decrease in cardiac output, which rapidly recovers with time. And this is what happened with mean arterial pressure. So some patients decreased a lot, some others tended to remain stable, even some others increased during the maneuver. And these are the individual values for the pulmonary artery pressure. And consistently, all patients during the recruitment maneuver showed a major increase in the mean pulmonary artery pressure. And perhaps this is important because there are some animal models indicating that when ventilating at high peak static pressures and at high flows, this may increase the amount of hemorrhages in the lung, or in other words, this may induce the sort of ventilator-induced lung injury. I'm just finishing. And again, data from the same group, from John Marini's group, indicated that ventilating with usual respiratory rate at 20 per minute, but using perfusion of pulmonary artery pressures of up to 35 centimeters of water, this combination again induces major pulmonary edema and a huge amount of hemorrhages in these experimental animals. So to conclude, the recruitment maneuvers may produce significant hemodynamic derangements, which seem to depend on the type of the maneuver and probably the partitioning of the respiratory system mechanics. These effects are rapidly reversible, and in experimental models, some acute hemodynamic changes induce pulmonary edema, and the long-term clinical consequences of these recruitment maneuvers are unknown. I thank you very much.